Hi guys, this is Dr. Greg. I am going to be doing your communication, which is chapter 21 in your F.A. Davis book lecture. So here's a list of key terms that'll be helpful for you to understand to read this chapter. Here are your objectives for this particular chapter. So what is communication and why do we need to discuss it? Communication, as we all know, is a basic human function. We need to communicate with people to get our message across and to be able to also understand the messages that we're receiving. Communication consists of both verbal and nonverbal messages. It's going to help you with building relationships, both at work and even socially. And it's going to help meet the physical, psychosocial, emotional, and spiritual needs of your patients, clients. We have different levels of communication. So when we talk about our different levels of communication, we have interpersonal. Our interpersonal is going to be a conscious internal dialogue, sometimes known as self-taught, and it can be positive or negative. Like, I'm going to ace this test, or, I'm not going to ace this test, right? Everybody needs to be in that positive mindset. Interpersonal is going to be that face-to-face conversation or any communication that occurs between two people. It's frequent form of our communication. Nurses use interpersonal communication to gather information during their assessments, to teach about healthcare, to explain, provide comfort and support to their patients. Group communication is interaction that occurs among several people. Small group communication occurs when you engage in an exchange of ideas with two or more individuals at the same time. Examples of small group communication could be a staff meeting, serving on a committee, educational groups, self-help groups, and even family teaching sessions. Public speaking is a unique form of group communication. Generally, the speaker addresses a group with varying degree of interaction. Nurses engage in public speaking to educate various size groups of people about health issues, lobby for health legislation, and to address colleagues at professional conferences. So the components of the communication content would be the subject matter, what we're talking about, the words we choose, the gestures we use, the substance of the message, and all of that can be open to interpretation by the person receiving the message. The components of the communication process involve 6 elements. We have our sender. The sender begins the conversation to deliver a message, which is the content, to another person. The sender, sometimes called the source or the encoder, uses verbal and nonverbal methods to transmit the message. Encoding refers to the process of selecting the words, gestures, tone of voice, signs, and symbols used to transmit the message. The message is the verbal and nonverbal information the sender communicates. It might be a conversation, a speech, a gesture, a letter, and so forth. Effective messages are complete, clear, concise, organized, timely, and expressed in a manner that the receiver can understand. The message must be appropriate for the situation and for the developmental level of the person receiving the message. The channel is the medium used to send the message. So face-to-face communication is a very common channel when we're doing our bedside nursing. If you are doing a telephone triage, the telephone would be your channel. If you were doing a text message to perhaps a boss or a physician about a patient change, then the text would be the channel. The receiver is going to be the person that is listening, is going to be the person that is interpreting your message. Interpretation is also called decoding. This refers to relating the message to past experience to determine the sender's meaning. The receiver uses visual, auditory, and tactile senses to decode the message. Feedback validates that the receiver actually got the message, understood the content of it, and responds appropriately. Verifying that the message was received by inquiring on feedback helps to avoid confusion. This is a visual representation of the components. So the active part of the communication. So we have the sender here who is encoding the message. And then we have the receiver who has to decode it. And then he's going to encode his feedback. And then she has to decode his feedback. And that's um, the active parts of communication. So this is a question that, unfortunately, since I'm recording this on my laptop, I cannot be in active screen mode to have this come across, but there'll be a few more questions throughout this presentation. So we have our verbal communication, and verbal communication is going to be the speaking part. So when we talk about factors that affect it, vocabulary. If you have a patient who has perhaps less than a ninth grade education, you are not going to want to use complex vocabulary. The average person who's not medically versed needs to have appropriate verbiage. So, again, you're not going to say that, they're having hypoxia. You're going to let them know that their oxygen level is low. Um, if they have, I'm trying to think of examples. If they're vomiting, you don't need to say, emesis. So it's just picking the appropriate words for the person that you're talking to. Pacing in conversation, you don't need to go super fast. Pacing is the rate of which we speak. Clarity, again, that would be once you've sent the message, does the patient really understand it? Timing means that the interaction must allow time for the response. A rapid flow of questions or one-sided conversation inhibits interaction and your understanding if the patient understands. Needs to be relevant information. So if you're having a conversation with a family or a patient, is this the best time to have that conversation? And then sense of humor and laughing are positive influences on attitudes and healing. Laughter can create positive physiological changes, and it could diffuse a tense situation. However, not everybody appreciates humor, so you need to be cautious of that. So our nonverbal communication is going to be all the body language. So your book cites this particular picture and they're expressing the point that the woman seems very sad and the staff member who's caring for her is smiling. And, this could be a very inappropriate situation. Or maybe he told a joke to try and cheer her up. So, all right. Now we have factors affecting nonverbal communication more. So facial expressions, right? Facial expressions can communicate feelings behind the message. We have posture and gait that can give us clues to the patient's attitude and their self-concepts. Gestures, hand and body gestures emphasize and clarify the spoken word. They're good indicators of the feeling and tone behind a conversation. Touch can convey affection, caring, concern, encouragement. Avoid using touch when dealing with somebody who is angry or mentally disturbed because the touch could be misinterpreted. Although touch can be highly effective, use it cautiously, be aware of your situations, your environment, cultural impacts with touch, and how your patient responds to the touch. Other factors, so environmental factors, communication is most successful in an environment that is quiet, private, free of unpleasant smells, and at a comfortable temperature. Think creatively to secure the most comfortable environment possible for communicating with patients and their families. Sometimes hospital chapels are a great place. Having something in an active lobby, if you're giving somebody difficult news, is not a good environmental location for that. You want to develop developmental variations, right? Physical and cognitive develop, language skills, level of education, and maturity influence the communication process. You'll need to modify communication strategies to fit your client's developmental level. And again, developmental, like they're learning, gender. Gender differences in communication are important. If you're taking care of a male patient who is not comfortable talking with a female patient, sometimes they will not want to look at you, they'll not want to interact with you. Some cultures, the male is the predominant talker of the family. A lot of Hasidic Jewish have that male, I don't want to say monarchy, but that's the best way that I can say it right now. They're the ones who's in charge of the family. So if the wife is there, he's going to want you to talk to him, not necessarily talk to her, or you might be talking to her and she won't answer you and he will answer you. And that's normal for that particular culture. Personal space, right? I have this little image up here. If anybody's seen this episode of the close talker, some people want distance between them, and other people do not have that same need. Culture can influence this as well. Territory refers to the space and things that individuals identify as belonging to them. Territories may be bound and visible to others or may be defined by individual way and might not be noticeable to other. Social cultural factors, cultural and social economic statuses strongly influence communication. Facial expressions, nonverbal, um, how they interact, are just all ways that culture can. And then we have roles and relationships as the sender and receiver after communication. They affect the choice of the vocabulary, tone, use of gestures, and distance associated with communication, right? So, a good way to look at roles and relationships is think about how you talk to a boss versus how you talk to a peer. Those communications might be very different. So you just need to be mindful that you use the appropriate vocabulary for the relationship you're communicating with. So collaboration, you can have an assertive person. Assertive means that they're going to communicate effectively. We can have passive. And actually, this is the whole list of the different communication styles. So the passive approach is going to be the person who really is unable to communicate their needs, their feelings, their opinions. Passive people avoid conflict. They allow others to take the lead. They tend to be submissive, indecisive. You could perceive them as whiny. Passive communications often apologize for their opinions, or even fail to express them because of lack of confidence. They have sometimes anxiety on how others perceive them. Then we have passive aggressive. This style of communication avoids direct confrontation, but subtly achieves their goal through manipulation. Passive aggressive communicators may appear cooperative, um, or passive on the surface, yet they're very well known for undermining and sabotaging the efforts of other. Then we have our aggressive approach. Aggressive communicators try to dominate others. They're going to want to be the winners. They usually will blame and criticize others, events, and situations. They're going to be poor listeners. They tend to be impulsive and they have very low tolerance for frustrations. And then we have assertiveness. So this style of communication is direct, it's open, it's honest, it's non-judgmental. It allows you to take responsibility for your own thoughts and actions without encouraging feedback and enables you to find mutually satisfying solutions to conflict by confronting people constructively. And that's kind of what we should all want to aim for. So, a little bit more on assertive communication. They're going to speak clearly and positively. They're going to maintain their professional composure. They're going to use I statements. So, kind of focusing on themselves that, I feel blah, blah, blah. They want to focus on the issues. They're going to accept criticism, and they're going to strive for compromise. So when we communicate with our healthcare team, we're going to use SBAR-Q, right? And we know that SBAR is situation, background, assessment, recommendations, and the questions would come at the end. And you would want to incorporate patient rounding into this. Remember that while you're sending that message with the situation, the background, the recommendations, then you're going to try to get questions from the person that you sent the message to, the receiver, to make sure that they actually processed everything and that they understand. The next thing we're going to talk about is therapeutic communications in healthcare. Therapeutic relationships and communications focus on improving the health of your patients, provide necessary information about healthcare treatments and care, and they're going to involve therapeutic communication. And what therapeutic communication is it is going to be client-centered, goal-directed communications that's going to strengthen your relationship with your patient. The therapeutic communication relationship has these 4 stages. The first one is going to be the pre-interaction phase. This is when you're going to be gathering all the information about the patient. You're going to be reading their charts, reading their consults, and getting a good idea of what's going on with them. Stage 2 is going to be the orientation phase. This is when you're going to establish your rapport and trust. And a good way to start with that is introducing yourself, who you are, and then finding out what their name is, what they want to be called. Then we get into the working phase. So during the working phase, the nurse is going to communicate caring. The patient's going to express their thoughts and their feelings. You're going to have a lot of mutual respect that's maintained. It's going to be honest, verbal, nonverbal expression. And then your termination phase. This is when the relationship's done, the conversation's over, the nurse shifts ends, the client's discharged from the unit or facility. And it's good to kind of go back, review, and summarize how it went so that you know that everything you said was received, decoded, and understood. So some key characteristics of your therapeutic communication. Number one is empathy. I like to use the example of empathy as, if you don't know what empathy is, it's being able to kind of put yourself into somebody else's shoe. And a while ago, I saw a really good YouTube video, and it was a little animal that fell in a hole, and another little animal walked by, and he poked his head in, and he's like, sorry, you're in the hole. And then he hopped on away. And then another little animal came down and actually like climbed in the hole and sat in the hole with them and said, this must be so scary for you to be down here. And that's the difference between sympathy and empathy. Sympathy, you say, I'm sorry, but you kind of just move on. And empathy is getting into that hole with somebody and feeling what they feel. Respect is another key component here. You're going to show that you value the client, that you're flexible to meet their needs. As a nurse, you must be willing to adjust to your client rather than expecting the client to adjust to you. And adjust the hospital routines. You have patients that might say, I take Synthroid every night before I go to bed. And the hospital usually prescribes Synthroid every day at 7 a.m. And a good form of respect would be to change that routine, the hospital's routine, to fit the client's routine. Being genuine, the ability to respond honestly, If you're unable to answer the client's question, do not offer guesses. Be honest, be genuine. Tell them you need assistance before you can answer the question, or you need to do some research. You're going to want to be genuine in your communications, how you handle situations, and how to improve your communications. Um, and then we'll skip down to confrontation. So, communication we know is a reciprocal process. If the client is unable to express their thoughts clearly, you must be willing to confront and to request clarification. This also goes with a physician. If you do not have a clear understanding, we're not saying confrontation as you're going to, throw down and fight with them, but you need to confront them and request clarification. Similarly, you must be willing to be confronted if you're unclear. So groups are enhanced problem solving and creatively generate understanding and support. They enhance morale. They provide a sense of affiliation. However, groupthink, a pattern of communication in which consensus overrides creativity and problem solving, can emerge, particularly in cohesive groups or those that are unbalanced powers of structures. So we have task groups, and these are going to be formed to adjust a task or fulfill a need. You might be in a task group to get the cauties down across the hospital. You might be in a task group to reduce door to EKG time. Then we have ongoing groups. These can address reoccurrent issues. So if the hospitals have reoccurrent issues regarding HCAP scores, they might ask you to champion a group to help with this. It's usually a little bit larger of a group. Self-help groups are voluntary. Sometimes organizations have these developed of individuals with common needs. Members are encouraged to share experiences and seek out support from other members of the group. So, common self-help group could be, Mothers Against Drunk Driving. Therapy groups are organized to help individuals cope and challenge. It could be for death of a spouse or a new mother, and then work-related social groups. Maybe your unit has a Facebook page for that particular group. So when we look at the assessment for a communication, we want to focus on elements that could identify factors that alter the patient's ability to receive the message, to transmit a verbal or nonverbal message, and those would be medications that they're on. Think about if you gave your patient some type of sedative medication, like an opioid or a sleeping pill, even an antihistamine, right? They're going to be too tired, too drowsy. Language. What if you have a patient who does not speak English? And your primary language is English? You would want to make sure that you have a certified interpreter. Their cognitive level, that kind of falls back to medications that would put them in less than cognitive optimal function. But you could also have somebody who has a cognitive impairment due to a stroke, due to a head injury, due to some type of electrolyte imbalance, right? All of that can alter somebody's cognition. Hearing, and when we get to our sensation lecture, we'll talk about hearing and vision and things like that. Aphasia, right? They might not be able to get the words out, or they might be able to get words out, but they're not going to make any sense. We can have physiological barriers, and then also communication styles. Some people like verbal communication, some people prefer to read. So all of that. So, some diagnoses or concepts that you might use for somebody who's having a communication could be readiness for the communication. They could have impairment with oral communication, just impaired communication, and you're going to want to plan your outcomes and evaluations based on whatever diagnosis you choose. Some interventions or implementations that you might want would be to enhance your therapeutic communication or identify barriers to the therapeutic communications, which would lead to further conversations with your patient. Some enhanced therapeutic communications would be to address your patient. Make sure that you're listening actively. Listening actively means that you're actually listening to them, and every once in a while you're going to, speak and make sure that, this is what you said, or this is, I hear you saying, X, Y, and Z. Is that correct? Establishing trust, um, making sure that you've identified how they want to be called, calling them by that appropriately, not calling them honey, sweetie, baby, or whatever pet names you might develop. You want to be assertive. You do not want to be passive aggressive with your patients. Silence. It is okay to have silence in a patient room. Next, we're going to talk about barriers to your therapeutic communication. So, a lot of times, students, even people in practice, have a very hard time with barriers to therapeutic communication. Um, and learn these lists, because if this is going to come back to haunt you in other classes. Um, but asking too many questions, if we ask too many questions, especially if we ask too many why questions, patients feel that they are being bombarded and picked apart and that you don't believe them, and you just do not want to do that. Fire hosing information. I feel like every time I give a lecture, I have to fire hose information at everybody to make sure that we get through all the content that we need to get through. But remember, when you're educating a patient, sometimes you're going to have to break those education sessions up into 25 minutes in the morning, 25 minutes in the afternoon, 25 minutes in the evening, 25 minutes before bed, rather than giving them, a 2 hour or an hour long information fire hose at once. Another thing is changing subjects inappropriately. So, a lot of times as nurses, we go in with a set to do. This is what I'm going to accomplish today. And I'm going to go in and I'm going to talk to them about their diabetes education. And I'm going to make sure that they know how to dial up the right insulin and they know how to purge that little needle on top of it. And I'm going to do it. And then you go in the room, and all the patient wants to talk about is maybe diet, and you're not really wanting to talk about diet because you really want to click your box off. And a lot of people will just change the subject inappropriately. And we don't want to do that. You want to make sure that the patient's ready to talk about and learn about what they want to. Failing to probe, that gets a little bit tougher. When we talk about sexual health, we'll talk about that more. There's a fine line between too much, not enough, and you'll get there. It takes time. Um, you never want to express approval or disapproval. It's not your role as a nurse. That's the role that their parents or their family can play. And you never want to offer advice. Another thing that nurses find a hard time with. Remember, there's a difference between advice and education. You do want to give them education, but you do not want to offer advice. And when you get into mental health, you'll learn more about that. In class, I'll provide examples of that. Providing false reassurance, you know, we want to be positive, we want to be optimistic, but you don't want to be liars about it. And false reassurance is essentially lying to your patients, and you don't want to do that. And you don't want to use patronizing language, because you're just going to alienate them and they're not going to want to communicate with you. Communication of cultural differences. All of us need to be culturally sensitive. Most important, be aware of your own culture's beliefs and attitude. Learn about other cultures, especially the cultures that are going to be in your area. You want to be able to convey empathy and show respect to all of them. You want to be certain that your communication strategies you use are culturally appropriate for the individual. So, like touch is something that you need to be cautious about. Sometimes we smile to be polite, but we do not want to be perceived as overly friendly or too casual. We want to make sure that we're using the right words, the right sentence structure. And if there is a language barrier, as I said before, you want to use a trained medical interpreter, not a family member, because if a family member might not understand the medical terminology, and that can, we actually had a case one time where they were having a housekeeper do a medical consent for a procedure, and the patient refused to sign the consent. And we found out afterwards that this person was not using the best medical terminology. They weren't providing all the details that the physician said, and it turned into a whole issue. So you want that trained medical interpreter always. Communication for the speech impaired. Hand gestures as appropriate, but be cautious of that. You can have the family help with this, but again, if the patient is deaf, then you are going to want to go back to that trained medical assistant. You do not want to have the family signing for you. If the family has certain signs because the loved one's hard of hearing and they have a sign for, hungry, thirsty, those gestures would be appropriate. And you always want to do what's best for your patient. When we're dealing with patients that have impaired cognition, we want to make sure that we're treating them and communicating them appropriately. So when we talk about cognitive impairment, it would be a patient who's having trouble remembering, learning new things, difficulty concentrating, or inability to make decisions that could affect their daily life. So we want to make sure that we always try to communicate the best that we can. Want to make sure that we're not rushing the patient, that we're going slowly. You're going to want to stand in front of them. You want to make sure that you provide reminders to them, frequently reorient them to what's going on, limit their choices so they can still make choices, but we don't have to give them 10 choices. We can give them 2 choices. And don't just assume, and avoid slang and jargon, because slang and jargon can confuse anybody, but it can definitely make your cognitive patient struggle a little bit more. And that is actually the end of this lecture. So thank you very much.